Good afternoon, everyone, and thank you for joining today's presentation. Please take a minute to orient yourself to our platform. If you would like to ask a question, please use the chat feature on the left lower-hand side. Technical questions will be addressed as they come in, and content questions will be addressed at the end of the presentation. If you would like to download the slides from this presentation, please use the icon on the top right. Additionally, live closed captioning is available at the bottom of the screen. My name is Chris Duff, and I'm a disability practice and policy consultant who has been working with the Loon Group to develop the disability competent care model and related webinars and materials. I will be joined today by Rachel Stakem, Senior Vice President for Care Management at Independence Care System of New York City. ICS is a nonprofit organization dedicated to supporting senior adults and adults with physical disabilities and chronic conditions to live at home and fully participate in community life. ICS offers two distinct plans: ICS Community Managed Long-Term Care, traditional Medicaid plan, and the ICS Community Care Plus for those eligible for both Medicaid and Medicare. In either plan, participants have a care coordinator and an interdisciplinary team. Rachel has been with ICS since 2001. She created their multiple sclerosis program in 2007, which was recognized by the National MS Society as a center for the promotion of excellence in long-term care. On behalf of the Loon Group, I would like to welcome you to our Disability Competent Care web series. The Medicare and Medicaid Coordination Office at the Centers for Medicare and Medicaid Services has contracted with Loon to develop technical assistance and actionable tools to support providers in their efforts to deliver more integrated and coordinated care to enrollees. This is the fifth of 7 webinars in this series, running on Wednesdays through March 22nd. All the webinars are being recorded and will be available along with a PDF of the slides at the Resources for Integrated Care website. There is no definitive definition of care coordination, and many organizations prefer to use the term care management. In the DCC model, we have chosen care coordination because we have heard from participants they don't like the connotation of being managed. In the DCC model, care coordination refers to a function or set of activities which are performed by the members of the interdisciplinary team individually or collectively as compared to a specific role performed by a specific individual. This lack of specificity is intentional, for the professional background and the skill set of the composition of the IDT needs to have enough flexibility to meet the unique needs of the participants they serve. Thus, the model describes functions of care coordination: primary care that is delivered by physicians, nurse practitioners, or physician assistants. Likewise, nursing functions can be fulfilled by registered nurses, nurse practitioners, or psychiatric nurses. Social service functions can be fulfilled by social workers, licensed clinical social workers, or by community health workers in some settings. The important thing is that together they bring these skills and the competencies to the functions of the team. Together, they all perform care coordination. Regardless of how your plan, provider system, or agency chooses to compose the interdisciplinary team, or whether all functions are not provided by one single entity, it is vital to ensure seamless communication and collaboration as they work the individualized care plan. First, though, I would like to provide some context for the disability competent care model and care coordination as a whole. Research has repeatedly shown that the population of people living with disabilities have significant health disparities. This is due to a variety of barriers, access in its many variations, as was discussed in the third webinar of this series, as well as the availability of screening, services, and supports. All this results in poor outcomes, including secondary and/or chronic conditions. A wide range of social factors also lead to poor outcomes. Many people with disabilities rely on Medicaid and/or Medicare for their health care. Medicaid, for example, is income and asset tested, meaning the recipients are living on very limited income and are financially challenged. These programs are going through extensive redesign, moving from fee-for-service to value-based purchasing. As the payers are increasingly focusing on outcome measures, such as cancer screenings, vaccinations, and diabetes management, the clinical interventions are straightforward, but communications and service delivery stretch the disability competence of many providers. Add to the financial, eligibility, transportation, and other challenges, is no wonder persons with disability experience poor outcomes. And thus plans and providers are learning they will achieve better outcomes if they attend to these challenges. At this point, I will hand the presentation over to Rachel.
Thank you, Chris. My thanks to the Lewin Group for having me here today. I'm happy to be with all of you. So I'm going to start off by talking about the team itself and how do we use a team to provide care coordination. I think over the years at ICS we realized we went through different models and ultimately came back to a team model because we realized that a participant, we call them members, so forgive me if I keep saying members, really requires different skill sets throughout the trajectory of their membership here. So we really found it beneficial for teams to come together, and that our teams here are comprised of nurses and social workers that have various backgrounds and specialties. We also see a need for primary care to be integrated in those teams, and that those team members really have to understand how to meet the needs of those with disabilities. And really that's understanding both what their tailored needs are required in regards to things such as mobility devices, what typical barriers are that they face, and then the resources that we can provide to address them. In addition, we rely on other team members with other skill sets based on the member's needs. So if we're working with someone that is no longer competent, we might have a guardian that's involved and is really working with us to bring the care plan to life. So it's really looking at the member and the population you serve to determine the need of the team members and what their skill sets. So whenever we talk about care coordination, and what this will be a trend throughout my presentation, it really should be based on what the participants' goals and preferences are. If we're not keeping that at the center of what we do in our work together, the likelihood of us being successful is very low. However, if that is at the forefront and is taken into consideration in all of our decisions, we tend to be much more successful. So when we talk about the key elements of care coordination, so to the next slide, at the forefront and from the beginning, what we are working to do is to develop and maintain trust with that participant. It's really hard to move forward if that is not present. And so we begin by really understanding, as I said before, what is important to them, how much do they feel like they are capable of participating in their health, and what's their willingness to. And often when we are assessing that, a lot of stories have come out how the participants' past history is affecting their current healthcare decisions and their belief in themselves or in the healthcare team. So really asking about where they've been successful in managing their health or where they have hit barriers is important and really will help you when you move forward. When you are setting up communication, again, in a relationship, it's like any relationship, communication is key, and we'll talk about that in a little bit, but understanding who their support team is and including them if they want them to be included, again, is critical. I think sometimes HIPAA has done us a disservice where we restrict so much information, but in reality, if the participant wants us to include their family and loved one in this discussion, then we need to do it. The support team, if you include their support team, again, you're going to be more likely to be successful. So when we talk about conversations, often in healthcare we're doing that without the participant, and it becomes not as efficient because in our teams, for instance, we'll talk about what's going on with someone and we'll try to problem solve and we'll put together a plan, and then we present it to the participant and they say, no, that's not going to work for me. So as much as we can, and it's changing our method, and I know that can be quite awkward and disruptive to our current processes, but if we can include the participant in those discussions, it can save us a lot of time. So figuring that out, including the participant when we can, and making sure that we have those key arrangements set up so that they are receiving the services they need is really important. So on the next slide, it's for people who prefer a visual. This is a way to think about the care that we're providing in the team members, and always at the center is the member. We start with the participant, and then we build the support around them that they need. This should be fluid and responsive, and we should take the participant's capacity into consideration and then build the support. So if that participant is able to lead their own care, they might not need a social worker. So really looking at where their skills and their willingness is, and then bringing the team around them. So some guidelines for the IDT to consider is really making sure, as I said before, that those providers have the training and the ability to provide quality care to people with physical disabilities. It's not a natural evolution, and as a healthcare provider, it certainly wasn't something I learned in school. We all start somewhere, and we have to build our expertise, and I have learned so much from working with people with physical disabilities and asking them about what they need, and then understanding, as I said before, the barriers to their care, the risk of their condition, the risk of immobility, and how to meet them and how to reduce those risks or totally obliterate them. When you're talking about a team, I always use the example of being on a sports team. I played soccer when I was in my youth, and we practiced before the season started. We came together and we practiced, and so we could get used to working together. And then throughout the season, we would practice every day during the week and have about one game. And that was really so that we could get to know each other's strengths, who's playing, what's the position, when should I pass it to someone. And the same is true here in creating an interdisciplinary team. We need to have clear roles and responsibilities. We need to know who we're passing it to and what they're going to do with it. And we also need someone to lead that, so that there is someone who's taking overall responsibility for the care plan and making sure that we're on the road to success. That lead role may change as the person changes and goals are reached, and we might move on to something else where the person who is currently the lead doesn't have the right skill set or to meet what the participant wants. So to ensure that we have some flexibility in that. In addition, skill set's important, but the other thing is that the person has a relationship. When we go back again to talking about trusting someone, and there are certain times, particularly when people are vulnerable, that having that relationship, saying, okay, this is good, Chris is here, I know Chris is going to watch out for me, and that can mean a lot. Okay. I apologize. I just somehow got kicked off from the presentation, but I have my slides in front of me, so I'm going to keep going. As it pulls up, we're going to move to IDT communication. So we talked about the what of the team, and now we're going to move to the how. How do we work together? And that is really, it begins and ends with communication. So when we're talking about communicating with the participant, again, starting by developing that trusting relationship, really how you do that is by listening. I think we often will rush to, particularly as healthcare providers, I call it fixitis in with my colleagues, because we have such a desire to help people and to try to fix the problem that we sometimes rush to do it before we truly understand what's going on. So really understanding what the participant needs from us, including if they're refusing something. If someone says, I don't want that, or they're not showing up, or they are non-adherent, diving into that with them and asking them to tell us why they don't want to move forward to that. I think asking what people value, understanding what people value and what they want for themselves, and moving from that model of what's the matter to what matters to you. Also, making sure that we know what they understand, because our healthcare system is very complex. Sometimes people's conditions are very complex. At ICS, we, on average, our members have 11 diagnoses. They are on 10 medications, and they require 8 hours of care a day to help them to remain in the community. That's a lot. So what do they understand about what's going on with their health? Do they understand their disability and what their functional capacity is? Are we maximizing it? Or is there something we might have to have a hard conversation? So for instance, we have people with progressive neurologic illnesses, such as multiple sclerosis or ALS, and when you talk about what's most important to them, sometimes they will say, I want to walk again. And unfortunately, today, we don't have the ability to do that when someone's disease has progressed to the point where they lose that. So you might need to educate them. But before you do, it's often good to say, may I offer you some education, or tell you, from my view, what we can offer you, and then to have a discussion and to explore what they want, and to be very specific about what we can offer and how we can help them. So in that scenario, for instance, one of the conversations that I often have is saying that unfortunately we cannot help them walk again, but we can help them get, where would they go if they could walk? And often we can be successful there. So within the IDT, again, communication is critical. I have a theme of telling people, let's set all of this stuff up before a crisis occurs, because then everyone's panicking and we don't know who to call and how to get them. So when you are setting up a team to set up a protocol, how do you want to communicate? Sometimes people don't like the phone anymore. They prefer secure texting or email. So knowing that, setting it up, sharing everyone's information. Because the other thing about an IDT is that you have to be responsive when it matters. So saying when it matters and when it doesn't, right? If something's critical, I will get back within X amount of time. If it is the standard, I will get back to you within a day or two, or whatever that is, so that people can set realistic expectations of one another. Again, setting a lead is important. Who is taking the role in this? The other thing is making sure that you know who the member considers on their team. So we might at ICS say, this is who is going to be on the team for Chris, but sometimes Chris has an idea about who's on his team, and he has other healthcare providers that we're not communicating with, and something, the likelihood of something going wrong because we're all off on different paths is high. So it's kind of like I said, when you're doing a medication reconciliation, you're asking people what are the medications you're on. I also want to hear about vitamins or anything else. It's the same thing. Tell me everyone who you reach out to on your healthcare team if you have a problem, and making sure that we know all of those people and that we reach out to those people. When we're also talking about a team, as I said before, like practicing, a team needs to meet on a regular basis. And I know everyone is incredibly busy, but making sure that we're sharing, are there any changes? How are we doing? Are we meeting our goals for that participant? How is the participant feeling about this experience? And that we're checking in on a regular basis. We meet every 2 weeks here at Teams. I will tell you, when we first did a case presentation, it lasted about 45 minutes because people were per participant, because people were taking, a while to explain themselves. And now that they've been working together for years, the cases can be discussed within 5 minutes because they check in with each other often outside of team meetings too. So when we moved to, we've created this beautiful individualized care plan, and we're ready to implement it. Now this is when the rubber hits the road. So it begins once it's completed. We've developed it. If you can move to the next slide, we want to see how it's going. It needs to be, as I said, we need to review it on a regular basis. When we set up that plan, we're often doing that assuming that what's currently in the participant's life is going to remain the same. So, for instance, their caregiver is going to be there to assist them to get to appointments or to remind them to take their medications. And unfortunately, that doesn't always happen. So making a point of checking in, but also realizing who are those key people or strategies that are going to need to happen, and then checking in to see how are they doing. How's the caregiver doing? Are the care partner doing? Are they able to fulfill their role? So that's really important. And then making sure, we live in a highly technological world now, so setting alerts can really help. Using electronic medical records could certainly assist if everyone's working off the same one. So alerting people to changes is important so that everyone's on the same page and is up to date with what's going on. I know that resources are really hard, and that people are trying to utilize resources where they're needed. And so when we're allocating care management to meet the participants' needs, it's really important to think about what's going on, what does the participant need, and who's the right person to do it. The critical thing is to determine the member's ability to self-direct and lead their own care. When we first started this, we started a stratification model. We did it by diagnosis. So we said, okay, well, everyone who's a quadriplegic is at high risk. We should have high contact with those people who have that condition. And then we learned that there are quadriplegics that are very self-directed, that are very knowledgeable about their health and condition and know what to do if anything goes awry. And who to call, and that they don't actually need us. So really seeing where the participant is and what they can offer. And then setting out, okay, well, here are these, critical points. This is when we need to touch base, and that every time you're moving forward, you've set up that plan, that emergency plan, and also the check-in plan. When are you going to circle back to see if you're becoming successful? And then can you set those alerts so that you remember. So that's at the individual level. The other thing to think about from the plan level and from management's perspective is the staff's time, and do they have the ability? So here's what the member needs. Can the staff meet those needs? And that we're continuously checking in on the staff to see what is actually doable, and can we shift resources if needed, because if it's not manageable, it's likely not to be successful. When we talk about tailoring services, so we have that individualized care plan, and we want it to meet the members' needs, and we know that one plan does not fit an individual, so we have to tailor it. So when we talk about tailoring it, often in plans we are looking at what services we can provide. And so those services really need to be tailored to meet that individual's needs. So that assessment, right, where is someone, where are they in regards to their health goals, their functional capacity, their risks, and how can we intervene and offer our support. We have found that the more flexible we can be, the more likely we are to meet the members' needs. I know that can be very challenging, especially for healthcare plans that have existing algorithms, and to look at that to see, and we have can we allow for some individualization or customization from our benefit package. So, and when we look at those traditional defined benefits, I think, for instance, I said, as I previously said, our members receive about on average 8 hours of care a day. It is a required service, personal care, an aide, a home health aide, that we're providing that. But sometimes there are barriers to doing that. So, for instance, if someone has bed bugs, having an aide come into the home is really putting the aide at risk. So even though extermination is not in our covered package benefit, can we arrange for that to come, or sometimes we have to pay for it in order to stabilize the person's services. We need to look at those social determinants of health and well-being that are impacting our participants. So, and I know consistency is important. So looking at something, setting it up for the staff, that you say, if you have an idea of a way of meeting a member's or a participant's needs that's not in our standard benefit package, then this is our protocol. You reach out to your team leader, and then the team leader knows where to go, so that that protocol is set up to allow for it. When we talk about putting this all together and where to keep it, that often is the individualized care plan is kept in the health record, and really, ideally, that's where you have a comprehensive composition of the assessment, the care plan, what the members' medications are, what their services they're receiving, and what those ongoing contacts with the participant or the IDT, what's going on with them. So ideally, I know it's not always possible, but if there is a centralized health record, that is where we want to go. Because you want the IDT, the health record really plays a role in care management for the IDT to see what's going on. What are we doing for that person? Are they calling? Why are they calling us? What's going on? And if there is a change, again, that those alerts are given out, that they're sent to the IDT. We also know that when the care team meets, things change in between. So if that health record is there, it can tell the team members what's going on when they check in. I know that there are participant portals that are available. We don't have this currently. We're hoping to do it. So right now we're reviewing this at least monthly with the member when we call. Outside of responding to any needs, we're saying let's sit down and go over what we talked about we wanted to achieve in this care planning period. So that's a way, if that's helpful to go around and then to get back to the team members by your agreed method of communication to let them know how it's going. When we talk about quality control within the electronic health record, again, that's a great tool to use. It will tell us, are people going in? Are they using the ER? Are they being admitted? Why are they being admitted? At ICS, about 60% of our hospital admissions are potentially avoidable right now, which I know, makes me a little sad, but also gives me hope that we can continue to impact it, because they're going in for things like urosepsis. So they had an infection that spread, or a wound that's deteriorating. So what are things that we can do? But the record is really a great way to see what's going on with that individual, but also at the population level, to identify what are the trends and do we need to develop any additional protocols to meet them. So always trying to reduce those health disparities and keep people as healthy as possible in living their lives. So hospitalization, I think, is a great intro where we talk about critical areas for care coordination. Where are parts when we think about people with physical disabilities that we really want to make sure we address? Care transitions is certainly one of them. Transition is typically referred to as when you move from one setting to another. It's usually a hospital or a nursing home. But when you talk about people with disabilities, it can have a broader scope. So for instance, at ICS, we have a pretty significant amount, I think about 10 to 20%, no, about 10% of our membership that have a history of homelessness because of various issues of inaccessibility or other reasons that they become homeless. And we work with a shelter called Barrier Free Living that's an accessible shelter. And so working with them to see, okay, they're going to have a change in their level of need when they move from the shelter and then back into the community. And what are things that we have to take into consideration? Those periods of time from transitioning, whether it's from hospital to home or from the shelter to back into the community, there is people with physical disabilities are at an increased risk for poor health outcomes that we really have to look for things and try to intervene whenever possible. So for instance, if you look at someone who is a quadriplegic and they go in the hospital, their aide cannot come with them. It's considered duplication of services. So then the hospital is responsible for meeting their needs. Moving from a one-on-one setting, right, where they had one person caring for them, to now having to share that with other people that are on the floor can be really scary. And if you're a quadriplegic, you can't push a call bell, the typical call bell. So making sure that there are things like a call bell that can be activated by touching your head or rolling to one side is really important. So because of that and because of our desire to manage those transitions, we've really set up a plan for people when this happens and protocols of what we do when we know that these critical points in time occur. Planning ahead whenever possible. So if what happens, what do we do? How do we respond if someone goes in the hospital? Using those protocols, checklists can be very helpful. So people make sure that they went through, those critical areas or those interventions and assessed what the member needs. Who is going to take that responsibility of following up? And, we at ICS, we learned that it can be incredibly disruptive, to a care manager when all of a sudden, they had planned on doing have a week set up and then a member goes in the hospital, and making sure, one, what they go in for and understanding that they're okay, and then trying to go in and help the participant. It can be very challenging. So at ICS, we set up a transition team that reach out to the hospital when we know someone's been admitted, to triage the situation, to see what the level of care is, and to go out if needed. And we found that helpful, and the members responded positively to it as well. So really making sure both in that transition it's being managed and then following that. And so, for instance, we use the Coleman model and making sure to prevent a readmission that someone understands their condition and the flags, as well as their medication reconciliation, and that they have a follow-up appointment, making sure that those things are in place so the transition team will follow them upon discharge too, to make sure those things are in place for the member, for the participant. Medications is also something we need to look at. Many participants are on multiple medications. As I said, 10 medications, that's a lot to keep track of. Using a health record is important for when someone has multiple providers or prescribers involved. The other thing is to always remember, I know there was a training on primary care, but making sure we're taking that disability into consideration. So for instance, if someone has fine motor problems with their fine motor movement, injecting might be hard, so are there other supports that we can put in place so that they get the needed treatment? Or if someone's on a diuretic and they have an unsteady gait, they could be at really a high risk for falls. Or if someone has to transfer on a diuretic to using a Hoyer to the bathroom, is that really feasible? Or maybe we need to come up with an alternative plan. I will tell you a tip is using a pharmacist. I know it's not often done, but I rely on pharmacists. They'll help you come up with a plan and to talk things through and to talk about that individual and what they may need and how we can come up with an alternative solution. Advanced directives is another area to pay attention to. When someone has a disability, you might not approach it the same way you would approach someone with able-bodied, meaning really thinking about what is currently going on with that person. So when we use the 5 wishes here at ICS, one of those discussed ventilations. We have members that are on a ventilator already. So how can you review that and with someone on a regular basis to say, do you think there will be a time when maybe you wouldn't want to be on a ventilator anymore? In order to do that, you have to have a trusting relationship with a person. It's in a crisis is not ideal because people feel pressured and you want them to think about it and have time to consider it. And again, it has to be reviewed on a regular basis because things change. I know I might have wanted something at a certain point 20 years ago that I no longer want now. So to really make sure that we're reviewing that on a regular basis. So I think we're going to move to a case scenario to go through, and this is about Camille. Camille is a 35-year-old woman who describes herself as an artist, an advocate, and a pet owner. I like Camille already. Her family, she has a support, but unfortunately they live out of town, but she's able to stay in touch with them. She is on the autistic spectrum. She has some hearing and vision loss, a thyroid disorder, and she's been having recently some problems with weight gain and difficulty ambulating due to swollen legs and pain. So she went to a long hospitalization. When we were thinking about Camille, I said a long hospitalization, automatically I go to she's going to need rehab, and that's what the hospital recommended. And Camille did not want any of it. Her identity is being a cat owner, so she wants to be back with her cat, and she wants her lifestyle is important. She does not want to go into a facility. So what did the team do? So the team, as any good IDT would, respected her choice and worked with her to develop an alternative plan, right? So what did we want for her in the rehab facility, and what can we bring into her home? So they brought in home care services, and they increased the visits to her PCPs so that they were seeing her more often. And they worked with her personal assistants to make sure they knew how to exercise so she could keep her weight down and keep the swelling down. And then Camille began to understand. She began to learn what's the connection between weight gain and her thyroid and taking her medications and her leg swelling. So she became more empowered and was able to self-manage more. And she also was able to get out there. She's an artist and share her talents. She got linked with the paratransit system so that if she needed more assistance, they could meet her functional needs. And so Camille is living her life. So if we're going to just, in conclusion, I'll just say I think, care coordination should really be the glue that's bringing everything together. So that glue should take the form of what that participant needs. And it needs to be developed. Communication is so critical, as is developing a relationship with someone. And it doesn't have to be a specific person, but a function or a role. What does that person need now, and how can we respond to it? And that's really important. And that it's a fluid, ongoing discussion with the participant. So I think this is where I turn it back over to you, Chris.
Thank you, Rachel. Looks like we might have some connection issues with Chris again. But I do want to thank you for that presentation. That was some great information that you provided to us. We've had a couple questions.
I'm back if you can hear me.
Oh, yes, we can hear you now, Chris, if you want to take over.
I'm sorry. Got to work on that, obviously. What I was just going to do is thank Rachel for her great presentation and call out a couple things she said that I thought were really interesting and pretty impressive. One, and these are actually quotes from her, that as professionals we are trained to fix. And she talked about learning to move from what is the matter to what matters to the person. And I think that's a classic example of what the entire disability competent care model is all about. So I wanted to call that up. The other thing that all of us, I'm sure, have heard a lot is people saying that what they want is a girlfriend, or what they want is to walk, even though they may have a spinal cord injury. And we do know that saying no, or that's not going to happen, isn't going to work. And so I really appreciated your suggestion that you go at it by a discussion, perhaps some education. Perhaps let's revisit that when I talk to you next or see you next. Just not giving the standard kind of medical response or clinical response. I thought that was also quite interesting. A couple questions have come in. First is, and a couple questions are kind of related. What triggers care management to get involved? And then secondly, who on the IDT talks most often to the members? Okay.
Great question. So we are a managed long-term care plan and a FIDA plan, and so care management is required it is a service we provide all of our members, and I know that's different in mainstream plans. So every single member receives a care manager here. And so typically upon enrollment, we look at a couple of different things, one being what's the member's condition. We, as Chris had said in the intro, we have a multiple sclerosis program here, a spinal cord injury team, and a dementia team. So if someone is coming in with one of those conditions, they more than likely will be on one of those teams. And then the team reviews the intake. We have one of our nurses go out before and complete an assessment, and that is taken into consideration in the team, and who do they think will be the best care manager to begin working with a member. And if we need to change that as we go along and the member's needs change, we will. And just to add, on average, we're talking to our members at least once a month, and then as needed in addition to based on what's going on.
Thank you very much. Another question that has come in is, can you give a few more examples of the benefit flexibility? You mentioned one or two before, but can you sometimes when your teams have said, it would really be better for the member if we did this. It could be improved outcome, it could be improved quality, it could be reduced cost. It could be a variety of things. But can you just give some further examples just to kind of trigger the participants' thoughts?
Sure. So one of the things that we can do is be flexible with our home care hours in the sense of it doesn't always have to follow a 9-to-5 schedule. So for instance, if someone wants to do something in the afternoon and they need their aide to be able to do it, they can have the aide come at 11 and then work 11 to 9. So we can be flexible with our hours. If there's a medical appointment and we need to give an additional hour for a day so that the aide can escort them home, we'll do that as well. Something we recently had happen was we had a physical therapist go out and see a member who has been having a little dysarthria or a slurred speech, and the physical therapist went out and said, wondering if someone needed an augmentative communication device, so for like a Dynavox, which can be quite costly. I know sometimes we've paid around like $8,000 for it. The physical therapist went out and she has a long history of working with people with disabilities and said, I think we could actually try an iPad to help her speak, and it's much less costly, right? It's under, I think it's a couple $100. And in addition, we could put some music on for her because she said when she gets stressed, music helps her relax. So it's a cost savings and it's an increased quality of life.
Those are great examples. I think I brought it up once before, but in a plan I was working with, a member came to us and said, my automatic leg bag opener quit, and I would like you to replace that. And obviously, leg bag openers are not in any benefit set, really. But when we sat down and talked with her, she said, it's really important for me to drink a lot more. I've heard that from my team. I've heard that from my primary care doctor. If I need to do that, I need to empty my leg bag fairly frequently, and therefore I will need to have a personal care assistant sitting on my couch much of the day. That's not a fun thing for me, and that's certainly costly. So for a matter of, I think it was $60, we replaced her leg bag emptier device, and everyone was for the better. So that's just another example of, if you give your care coordinators, give the people who are closest to the participant the ability to think outside the box, I think it will benefit everyone involved. Another question, and this, it's interesting, this question has come through in many of these webinars, and that is really the whole issue of working with primary care physicians and primary care practices. So why don't we start with, how do you prepare your care coordinators for working with primary care physicians?
Sure. So you're going to notice a theme here. It's the same kind of conversation to have with your PCP. So before we start working, if we're going to have, we have a group of physicians that we've worked with and care providers, nurse practitioners, and PAs that have disability competency. And so when we wanted to have disability competency and we wanted to help them get that, we went in and talked with them and said, what do you value in your role? Where do you get stuck in that? And we looked at what we can offer to fill that. So for our care managers, we shared that and we said, okay, we set up protocols. This is what we're going to do. So for instance, we used SBAR. So the providers came back and said, we don't have a lot of time. So if someone wants to share some information, how can they make it as concise as possible? So we taught our care coordinators how to use the SBAR tool, which is what's the situation, what's the background. And going through that assessment and recommendation, and we sent it the day before we were going on the visit so the provider could read it and have some time to come in and then have a very direct conversation with the participant. In addition, follow-up was really important. So if you want any relationship, if you say you're going to do something, do it, right? So we really developed tools so that we could track if someone was coming out of an appointment with a list of things they needed to do. Let's integrate it into our plan here, our care plan here, and let's follow up and make sure that we're actually delivering on what we said we would. That's great. I know that you've struggled with that model at first, and it seems like you've come into some training and a pattern that seems to be working better. Yeah, and it's a work in progress. I mean, it doesn't happen overnight.
That's what I was hoping you'd say. Exactly. How do you facilitate communication? And I hear this, I don't know a plan or a treatment team that doesn't have this issue. How do you facilitate ongoing coordination and communication between primary care and the remainder of the team if the primary care is not in the same site?
Right. So I think I might have referred to this in the presentation as really when you're engaging with that person before a crisis occurs, asking them, what's your preferred way of communicating? When do you like to be updated? What's the information you need to know? I will tell you, I practice 1 day a week, and sometimes I get these reports from a certified home health agency on one of my patients, and there is so much information in there, and I don't really know what they need from me. And so I think figuring that out and having that ongoing check-in, how is this working for you? What works well? What do we need to change with the provider? When I reached out to you and shared this with you, did you want to know that, or was that not appropriate? So kind of triaging that as well. But again, it takes time, and people have their preferences, and making sure that the participants' needs are being met is critical, right? So it's ongoing.
I think probably the last question is from Dr. Sonder, and I think it's a great question, and it's going back to the issue of healthcare directive, advanced healthcare directive. When should that discussion take place, and who should be on the team that makes those decisions? Does every member need to have advanced directives? And if not, why not?
So we are required to talk about it at enrollment and at every care planning period, which happens at least every 6 months. It's really important that people understand what the purpose of an advanced directive is. And so at our first visit, it's a lot. So we introduce it. If they don't know what it is, if they don't have it, we provide information. And then that care manager goes back and really facilitates that discussion. If they don't know what they want, it's then brought back to the primary care provider or their preferred provider. So again, some of our people in the MS community trust their neurologist and want to talk through some scenarios, so it really depends on who they choose as or identify as that person. It really should be, that discussion is led by the care manager, but the member is making those decisions. And so that's why, in order to make an informed decision, sometimes they need to talk to their provider about a scenario. When you go talk about disability competency, we know, for instance, what a typical scenario, our members pass away from urosepsis, from wounds, infections due to wounds. So we can sometimes talk through a typical scenario for someone and what would they want in the event that they weren't able to communicate for themselves. But a lot of times we're bringing the provider in too. And then if not at the beginning and in the discussion, so that he or she knows what the member has decided. And again, that's reviewed every 6 months at least.
Great. So is that a conversation that's best with the primary care doctor, with the nurse, the social worker, a specialist?
We have seen all of the above, Chris. It really goes to what's going on with the participant and who do they want to have that discussion with. And who do they have that relationship with? I've seen social workers create great advanced work with the member so that their wishes are out there and are very clear. I've seen everyone, our nurses do it as well, and primary care providers and neurologists and physiatrists.
Great. That's I was guessing that, but and then this question goes real quickly to really what you were just kind of talking about. Is, in your experience, who on the treatment team talks most, or the interdisciplinary team, who talks most with their participants? Is it the nurse? Is it the physician? Is it the social worker? Is it someone in the office?
Well, we don't have physicians on staff. Everyone's assigned a care manager here, and that care manager could be a nurse or a social worker, and that's really who they're having the most contact with. But it really, it depends. That's our plan here.
Yes. Okay, great. Well, with that, I think we have to wrap it up. I would like to thank everyone for participating in today's webinar. Please send any feedback you have to the address on this slide and answer the survey that will appear on your screen at the end of the webcast. Again, I'd like to call your attention to the resources we have outlined at the Resources for Integrated Care website, including the Disability Competent Care Self-Assessment Tool. Please join us 1 week from today for our 6th webinar, Disability Competent Behavioral Health. The presenters will be Dr. Andrew Jorgensen, Assistant Medical Director of the Outer Cape Health Services, and Marta Hansen, Director of Behavioral Health at Outer Cape Health Services. I would like to again thank the Center for Medicare and Medicaid Coordination for sponsoring this webinar and the entirety of the Disability Competent Care work. Thank you for attending.